Good afternoon, all. I just want to thank you all for joining us today for this wonderful event, our prostate awareness event in the era of the COVID-19 pandemic. Today, you're going to hear from some community folks that you all know, Rep. Marjorie Decker, Mayor Sumbo Siddiqui, and others, as well as President of the NAACP Cambridge branch, Ken Reeves, and many others who have come together today to talk about a very important topic. This is going to be hosted and is being hosted by the Cambridge NAACP and the AdMeTech Foundation in partnership with the Good Samaritan Medical Center. So we're glad that you could join us today. Just to let you know a little bit of the sort of ground rules and just giving some information out that this will be recorded and this program will be shown in other places at other times. I just want to also welcome Juan Cofield of New England area president to this event, as well as all of our other distinguished guests that we can maybe recognize towards the end. So first and foremost, I just want to speak as the vice president of the Cambridge branch of the NAACP and wearing a little bit of my public health hat, just speaking to the issue of prostate cancer as a Black male, but not only as a Black male, but as someone who, with all of you, has endured this pandemic, which has in a strange way affected us all differently. And I know for a fact that the statistics would show that there are many cancers that have gone undiagnosed because people weren't engaging in the healthcare system. And as a Black man doing Black man's health for the last 20 years, I can tell you that prior to the pandemic, there wasn't the engagement necessary for people of color, particularly men of color, around this particular issue. So today's conversation will be a broad-ranging conversation talking about the effects of the pandemic on healthcare and people in communities of color in general, as well as speaking specifically on the area of prostate cancer. And I think that our program and lineup will be one that you'll enjoy. It'll be informative, and it'll teach you a little more today about prostate cancer and the pandemic than you probably knew yesterday. So I'm going to start off by introducing, to say a few words, my good friend and high school classmate and forever shero, Rep. Marjorie Decker, to speak to the group and give a few words. Rep. Decker, the floor is yours.
Thank you, Richard. It's so good to be here with you and to be here with both our Cambridge president, Ken Reeves, our New England regional president, Juan Cofield. And I know that you all can't see her, but I got a peek. Aisha, who is there with her beautiful new baby, of course, working less than a week after giving birth. And our mayor and Reverend Thornhill, I see your name, so just saying hello to you. And that, thank you for having me here. First of all, it's just, it's hard to still not be together in community, in person, but I still feel very grateful that we have the chance to keep these conversations going. And Richard, what you said is, it's really important. The pandemic has exacerbated the inequities that existed before the pandemic. And when it comes to the racial inequities that exist in our healthcare system, which then lead to statistics that represent that in health outcomes for people of color, when you're comparing them to European white people in our communities, they're startling, and they should be front page news every day. So I come here and I appreciate the invitation, not only as your high school classmate, but also because I have an enormous responsibility as a state representative from Cambridge and as the chair of the Public Health Committee for the House of Representatives. And I think a few things to think about that I will just, open this with is that we know that the statistics for COVID, the startling gap of who caught COVID and who died from COVID absolutely linked back to issues around the social determinants of health, which always brings us to people of color disproportionately being harmed and impacted with worse health outcomes. That is also true for prostate cancer. We know that men of color are diagnosed, have a higher diagnosis of 2 times higher than that of white European Americans, and also die at a 2.5 times rate more. What's important, just like all of the health inequities that exist, it's not inevitable. It's not biological. It is because of the baked in racism in our healthcare systems, which is, again, why you see the disparity between who experienced COVID, particularly before the vaccines were available, who had higher rates of sickness, hospitalizations, and deaths. And so really it's incumbent upon those who are in decision-making places, legislatures, local government, school committee, healthcare providers and CEOs, insurance companies, to say in every step of the way, are we looking through the lenses of racial equity? Because it is, to be in Cambridge and to be in Massachusetts, you know, you have to be talking about racial equity, and we talk about diversity and equity inclusion, but that doesn't mean that those lenses are being baked into every decision, policy, and budget that we do. So when we look at screening, we know that in the year 2020, there was a 30% decline in prostate cancer diagnosis for all men. That's not because fewer men had prostate cancer. It's because of the delays in healthcare and the access to healthcare that were exacerbated by the pandemic. And so when we, you know, and I think it's important when we also talk about these startling statistics, often if you read in the literature and the data that's out there, the statistics frame them as if you are in that category as a man of color who has a higher rate of prostate cancer or is going to experience morbidity from prostate cancer, the onus always seems to be written in a way that puts that on the man of color, as opposed to the healthcare systems that by design are actually not doing their job to increase access to screenings, to increase engagement and education and treatments. And so I appreciate being asked to come here to join you today. And I just say that I recognize it's about this incredible role and awesome privilege that I have to chair the Public Health Committee, to say that when we are looking at all of the bills that come through our committee, my staff and I are all tasked with making sure that all of the data that we understand around health inequities are being looked at through the lenses of how does this actually impact communities of color in Massachusetts. And obviously, I always have an eye on what's happening in our community in Cambridge, but to make sure, are we in fact pulling all the levers? So when we look at equity, it's about making sure that are we doing more in certain areas or communities to make sure we have equal outcomes? Because what we do know is that when men, white European men, white men, and men of color get to that 5-year marker of survival after being diagnosed with prostate cancer, that the survival rates are on par and they're equal. So I just want to say, I really think this is such an important conversation, and to the Cambridge NAACP, you guys have been doing really important conversations over the last couple of years and really utilizing the opportunity to bring people together who actually might not show up and have this conversation if the only option was to come and do this in person. And these conversations are important because it allows policymakers, decision makers, community members, community leaders to also hear the voices of our community and understand that the data and the statistics are actually tied to a responsibility of our neighbors, our loved ones, our family members, our newborns, and that the outcomes are a result of systemic racism and policy and budget choices. They're not inevitable. So thank you for having me today as a part of this conversation.
Thank you, Rep. Decker, and thank you for touching on so many important things. I think that as we talk about this, and President Reeves reminded me of this, that the pandemic has been so tough on community of colors in general, that we always have to keep in mind all of the things that are happening. Life happens while there's a pandemic, and these diseases that are afflicting communities of color, they're no different. So thank you, Rep. Decker, for your wisdom and insight. I want to now introduce our Mayor Sumbo Siddiqui, who had the fortunate timing to become a mayor in one of the city's toughest times. And I think that she doesn't get enough credit for her courageous leadership during that time through the pandemic. If people don't know, basically by most statistics that people are counting, the city of Cambridge did really, really well as it relates to preparedness in dealing through the pandemic. And that is in no short credit to the leadership of Mayor Sumbo Siddiqui. So Mayor Siddiqui, can you come on and talk a little bit about this issue and just weathering through the pandemic from your leadership post as mayor of our fair city?
Of course, I thank you so much for having me for this important discussion, and thank you to the Cambridge NAACP and President Reeves, who was my mayor when I was in high school, and the Vice President Harding as well. And I remember in March 2021, as vaccines were becoming available, Richard and I, we were at the towers. We were trying to make sure that everyone knew that they get a vaccine. We were setting up clinics. And I reflect on that time, and I think about how COVID has had a huge impact on our Cambridge community, particularly our Black and Brown residents, who, as Rep. Decker mentioned, experienced higher rates of COVID. We've lost so many loved ones. We know that so many of our community has lingering effects of COVID. And I also have reflected on what we could have done better during that time. And I think one of the things was, as much as we did get to testing and vaccines, I think we could have probably done it much earlier. I think it took a little time to realize that we had the resources to go to our communities. And I think when I think about an issue like this, I often ask, what does good engagement look like when we are trying to inform our residents about prostate cancer? And I think the Cambridge Health Alliance has done a lot of work. I know that Cambridge Public Health Department has done great work. I know that every September, in observance of National Prostate Cancer Awareness Month, the Health Department urges all men ages 50 and older, as well as younger men who are at higher risk, to speak to their doctors. We do a lot of awareness about getting prostate screenings, and I know that the Mount Auburn Hospital offers free prostate screenings throughout the year through its Men's Health Center. I also know that in years past, the Mayor's Office, the Health Alliance, Mount Auburn Hospital, the Health Department have sponsored citywide campaigns to educate Cambridge men about prostate cancer and offer free screenings. And outreach workers have gone to churches, barbershops, and the hoops and health basketball tournaments as well. I think what COVID also did was, we were focusing so much on COVID that I don't think we had, at least my term, spent enough time on important issues like this. And I think it's really my goal to now work with the NAACP, the Cambridge Health Department, and many others to collaborate to raise further awareness in our fight against prostate cancer. So I think it is really about being in the community, going door to door, making calls. And I think that's how we really were able to reach our most vulnerable during the pandemic, by going to them. And in the same way, given that this cancer discriminates, we have to work even harder to reach our residents who are most impacted by this. And so, I'm really excited to get to learn more about the topic at the Zoom today. I'm excited to learn more about how my office can partner with you all to do more on this issue. So thank you so much for having me, and I look forward to hearing the Q&A.
Thank you, Mayor Siddiqui. And I think one thing the mayor talked about was just the grassroots efforts. And so that day in, it must have been the fall, right, Mayor Siddiqui? We were out, a group of us with the Cambridge Community Corps, the mayor and some other folks, literally banging on every door in Ringe Towers, which is a place near and dear to many of us, but the mayor actually grew up there. And what the mayor talks about is so important. I'll give you a quick story before I go to our President Reeves. When the community jumps in on these issues, that's where you're going to find the people that are most needed. My uncle, one of the dearest people in the world to me, was diagnosed with prostate cancer because of an event we had with the Public Health Department during the mayor had mentioned Prostate Cancer Awareness Month. And we had a van that came to with the Windsor Street Clinic at 119 Windsor. And that's where he actually was diagnosed, just as a community thing where people were there and they had some basic tests that could detect irregularities as it relates to prostate cancer. And then he was diagnosed, and then he has now beat and is a survivor of cancer. So I think what the mayor says about the grassroots efforts, I think they're so underrated as it relates to reaching marginalized populations. To that end, I want to bring up our president, Ken Reeves, who will speak about his life experience dealing with the healthcare system, particularly his battle with prostate cancer. Former mayor and president of the NAACP Cambridge, Ken Reeves.
Thank you, Richard Harding, our first vice president of the Cambridge branch NAACP, and thank all of the other participants and speakers thus far. I can't thank you enough for joining us today. Now, most of you know I'm a pretty private person, but in planning today's program with the AdMeTech Foundation and Dr. Stern, I said, well, you know, our constituency in Cambridge, particularly the men of color, they benefit from hearing from someone like them who had the problem. I'll put it that way. So I said I'd put myself out there, and that's what I'm here to do today, to tell you how I, not unlike Richard's uncle, I kind of went to the urologist because I had a pimple, and I was afraid that if I kept picking with this pimple, I would cause some sort of infection. So the urologist determined, well, this pimple is benign, it can stay or it can go, it's up to you. So I said, I think you should get rid of it because I know I'll pick it and make sure that it gets infected. And so I was at that visit. He says, why don't we get some blood work from you and see what your PSA or your prostate specific antigen test level is. So I went and had that blood work done, and lo and behold, I was found to be in stage 3 of prostate cancer. Now, there are earlier stages where they kind of watch and wait, but if you're stage 3, you have to do something. So I began this journey where I went and I was given essentially some choices of which therapy I wanted to get rid of the prostate cancer from the prostate. And I decided that I would have this very fancy newer treatment called CyberKnife, because it only took 5 visits, and it seemed to me that it was the cutting edge of what was happening now. The other alternative for me was to have had, I think, 30 visits where you go every day of the business week for a month, and that seemed like the old way to me. So I had CyberKnife, which is only available a few places. I tend to like to go with the cutting edge treatments. And after the CyberKnife, things went well. I had some, in addition, hormone shots that went to follow up the CyberKnife treatment. And I went for my 1-year checkup, and things were perfect. No prostate cancer. And then after but I was to have some more of these hormone shots. The old protocol was you have 2 after CyberKnife, and they had just changed to 4. Well, I was barely able to tolerate the 2 because just everything went out of whack. Blood sugars, you name it, went out of whack. So I went for a second opinion about whether I should continue these shots, the full course of 4, and I ran into a wonderful physician who explained to me that many women during breast cancer had been over-radiated, and maybe since I didn't have so much prostate cancer in the first place, maybe the 2 shots would be enough if I was having so many side effects. So I took her advice to be wisdom, because the hormone shots were really turning me upside down. So I stopped them, and my 3rd follow-up appointment, my PSA number, prostate specific antigens, had increased to 9. And then another visit, it was 14 and another visit was 18, and couldn't quite determine why was this number going up, because we went back to the prostate and kept testing it and finding no prostate there. So I was in quite a conundrum, and I happened to be talking to my regional president of the NAACP, Mr. Juan Cofield, and I was explaining to him that I was kind of in the valley of the shadow. I wasn't clear on, no one seems to know why this is going up. I'm getting second opinions everywhere. My cancer doctor is telling me, you know, you may be in danger of being over-doctored because you live in a place that there are 3 different competing cancer health treatment systems, and you're getting, so I thought, well, now this is where I am. So Juan said to me, I can't leave you in the valley. I gotta get you to Dr. Stern. So I said, well, okay, 2 brains will be better than 1 here, because I really don't know what to think and do. So working with Dr. Stern, I've had the second opinion where the lady said, I can't really tell you what to do because they've not given you the right test. You need a PSMA test and a PET scan, and I will find that test for you. And that doctor was not able to find that test in Greater Boston. So we think in Greater Boston, we have access to everything. But no, this test could not be had here at that time. So I needed the test, and I told this to Dr. Stern, and she, with her magic wand, was able to get me in line for that test. That's the famous Sloan Kettering in New York City. So suddenly I'm learning Boston may be the citadel for all great hospitals, but they don't have this test. And so about 3 years ago in June, I traveled to New York City, and this is an imaging test, because the problem that I was having is there was evidence of prostate cancer, but not in the prostate. So the question was, where is it? And this is a fancy, fancy imaging test that will find it in your body, which was approved in Europe at that time, but not in America. Now, this is a long saga. I want to land it and say that I was able to find out from that test that the cancer had traveled to an area near my lung, and I'm now a patient at the Dana-Farber, which is the kingdom of cancer, due to Dr. Stern. And everybody I have now is the head of their department and in the nth degree of science, and I'm having stupendous care. But the one thing I have to tell you, and this is my message to my good brothers in Cambridge and beyond, Dr. Stern said to me at the beginning of our engagement, are you happy with the doctor that you have? And I said, no. And I said, the reason I'm not is I have been to that doctor 5 times, and the last time I went to him, he opened a folder and referred to me as Mr. Brown and started telling me about Mr. Brown's results. And I let him go on. And then about 5 minutes into it, I said, you know, doctor, I can't tell you how disconcerting it is to have seen you the number of times I have seen you, and you to be sitting here giving me Mr. Brown's results, and I'm Mr. Reeves. And Mr. Harding is in this story too, because when I left the doctor, I was so outraged. I had a meltdown on the sidewalk on the phone telling him this. And the thing I want to say is this prostate cancer is very common amongst Black men. And I have sat in some of these waiting rooms with all these older Black men who's sitting with their daughter and their wife and whatnot. And I really felt in my case, my doctor was used to, just sort of servicing the cattle as they come. I don't think he was too, well, he certainly didn't know their names, but the end of my story is, I think, a good one in that I now know how to navigate the system and I have someone to hold my hand. And that's something, the major reason that the Cambridge branch of the NACP signed up with AdMeTech, because they are offering to be our partner in the city of Cambridge for men of color to help guide them through a system that is difficult at best. And, I've been to Harvard and MIT, and I have had many moments when I felt that I needed 3 or 4 brains better than my own. But I'm pleased to say today I'm 00.00 on my PSA number. And I'm going to brag to you that I'm in an experimental therapy where I take 4 pills every morning, which are valued at $1,000 each. So I'm an expensive patient who is in line for a true cure so far. And I would say this cancer journey, even when you are not having evidence, it doesn't end. You have to yearly check and see if anything has returned or other problems. But so far, so good. And it's all because I've had the best of care. And I've been introduced at the top of the heap by Dr. Stern and her circle. She doesn't tell you much about her background, but she really, this is just one of the things. She was the chief person at Children's Hospital for essentially imaging. Imaging covers X-rays and all those things, but to have that responsibility at Children's, where everything is of heightened importance, but she has done many things in addition, and she can tell you some. But I'm just wanting people to know that you can beat prostate cancer if you pay attention and attend all of your appointments. I learned that from our Marvin Gilmore in Cambridge, who's over 90 years old. He says, the key to Black men's health is go to all your appointments. So I'll say that. I think I'll land there, Mr. Harding. Thank you for this opportunity. I think you shouldn't cry about these diagnoses. I think you should cry out for help. I got help through Dr. Stern, and I'm so glad about it.
Well, thank you, President Reeves, for sharing your story. It's not always easy, obviously. I know that I've tried to be as supportive as I can with you, but I'm grateful that you understand and you have chosen your own path. And I think that that's something that as a community, we need to help men do more of. Really think about taking charge of their health when they have, regular appointments or when they have, information from a doctor that isn't so good. So we should work towards that end. I want to introduce Dr. Stern. She's going to address today the recent advances in prostate cancer diagnostics and the Prostate Cancer Equity Program. I just want to say thank you to Dr. Stern in advance, because she doesn't know this, but we had crossed paths through the public health department and my men's health project years ago, but we weren't able to pull it together. Some of it was because of where the organization, the CHA, was going around prostate cancer. Some of it was we just couldn't do it. And then the pandemic hit. And so life is interesting, because we came back around full circle when the president called and said, I have this group, AdMeTech. And I just remember actually Tom, who was to follow up with my former colleague, Albert Pless. And now we're here today. So there is a such thing as destiny. So Dr. Stern, if you would come on and speak about the recent advances in prostate cancer diagnostics and the Prostate Cancer Equity Program, we would appreciate it. Dr. Stern.
Thank you so much. Actually, Mr. Reeves was our probably first patient for Prostate Cancer Equity Program. which is a new program. Historically, first of all, I would like to start with expressing gratitude to Representative Decker, who is one of many legislators who actually made it possible and provided funding for us to have educational events, to have research, and to have medical education. So I'm very grateful, Representative Decker, and generally to Cambridge delegation that was so important for many years for funding of our different programs. Now, traditionally, we have, before I will proceed also, I would like to acknowledge two members of my staff who are here today. Thomas Satam, who is Director of Operations and Health Policy, and Trisha Kinney, who is our Health Policy intern. Guys, thank you so much for being here on Saturday. And traditionally, until 1 year ago, our efforts focused on community education and public awareness and research primarily, as well as medical education. And over the last year, although Dr. Kwok Jing from Brigham, who is here today, although we've been talking about prostate cancer equity program, if I remember correctly, Kwok from 2015, we finally, about 1 year ago, sort of established this program. And Mr. Reeves became our first patient. And the goal of the program, unlike education, is to give direct access to every man who comes to us to the best approaches in screening, diagnostic, and treatment available today, not to mention the best doctors who have this approaches, such as Dr. Trink, who is here with us today. Unfortunately, at that time, when Mr. Reeves came to me, PSMA molecular imaging was not available in Massachusetts. It became available a few months later, since August 2021. I will address advances in diagnostics and prostate cancer equity program to a great extent in my talk, but what I want to say that this new program we completely understand within the context of this program that our focus, the focus of the program is on underserved men, Black, Hispanic, and Latino individual. We completely understand that this is community that does not have great trust in medical establishment. And it was important for us to create not only, to improve not only access to leaders at the cutting edge of patient care for this community, but also to create a process that will support men every step of the way. On several occasions, when I was working with Mr. Reeves, he told me that I was fierce, that I did not let anything sort of slip by, and if they need to be, I fought for him. And I want to mention what actually underlies my passion for fighting for patients and why we created this program to begin with. And I want to, we prepared a video for my presentation, but a brief video because we had so many problems, technical problems with presentation in different events. But before we will play this video, I would like to share with you a story. Actually, it's a story about my father, still in Soviet Ukraine. But a story that shaped me, who I am as a person and as a physician. I was about 10 or 11 years old, but I was old enough to know that it was, you know, parents of some of my friends would disappear. Nobody had, people were imprisoned and nobody had any justice. Even at that young age, my friends and I knew that. And I was always very scared for my parents, who my father was a physician fighting for his patients. My mother was a teacher fighting for her students, and I was always terribly afraid for them. And one day my father came home very early in the morning. He spent a night at the hospital, and he was scared. He said, look, we had surgery on this 5-year-old girl. I don't know where she's coming from, but I was assisting during surgery. And the light went out in a hospital. And he said, I called, at that time, there was electricity ration situation in Soviet Ukraine, economically was devastating. And here is a young 5-year-old girl with her insides open on surgical table, and there is no light. And everyone knew that this young girl is going to die unless electricity is restored. So my father called electricity station, whatever it was, and he told them, look, we have a young 5-year-old girl, help us save their life, please give us light. And they said, absolutely no. To him, to chief of the hospital, to everyone. So next time my father called, he said, oh, I forgot to tell you something. Do you know that this girl is a relative of such and such person? And he mentioned someone in charge of that entire region. And it was happening at around 3 or 4 o'clock in the morning. And they said, why didn't you tell us earlier? He said, you want to check? Go check. And he knew, and he was absolutely betting that they would not dare to call this man at 3 or 4 o'clock in the morning. So because they were not sure, they restored the light, and the girl's life was saved. And my father was very scared because he knew somebody would tell this guy in charge of the region that his name was used. Predictably, we all got scared. Predictably, my father was called to this man's office. We are all shaking in our boots. He entered this man's office, and this man is asking him, okay, I understand I have a new relative who is 5 years old. And my father started apologizing for using his name. And he said, do you even know this girl or her parents? And my father said, I don't. I just could not imagine for a young girl to die on a surgical table. And this man in charge of the region told him, okay, I called you here because I want you to be a physician to me and my family. If you fought for somebody you do not even know, you will fight for us. And this became friendship between our two families until we left Soviet Ukraine. And this story, ever since that time, my father always wanted me to be a physician. And my father told me the same thing, that people are vulnerable when they come to physicians. People are scared when they come into the medical system. It is our responsibility to fight for them when they cannot fight for themselves. And this really shaped me as a physician. So in many ways, prostate cancer equity program that gives everyone direct access to the best we have in medicine today and to the best experts is my dream project. Trisha, if you can please play the presentation video we prepared. My name is Faina Stern. I'm a physician and founder of the AdMeTech Foundation. I'd like to thank Cambridge NAACP and AdMeTech staff for organizing this educational event. Thomas Satam, Summer Mills, Emma Coyard, and Trisha Kinney in particular. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national and international levels. Our programs transform patient care for everyone and reduce health disparities in Black men. The goal of my talk is to describe our new prostate cancer equity program launched recently in collaboration with Dr. Kwok Ding Trinh of Mass General Brigham. He is participating in this event. I will also briefly address recent advances in screening and precision diagnostics, while Dr. Trinh will review the cutting-edge treatment. Mission of the Prostate Cancer Equity Program, or as we call it PCE, is to ensure equal access to these rapid advances in patient care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference with its multiple branches located across the state. Prostate Cancer Equity Program was launched recently as a new addition to the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. Our primary focus is on high-risk men, particularly Black, Hispanic, and Latino individuals, men with family history of prostate cancer, particularly in father or brother, and increasing age, 50 and older. This program was initiated since 2009 in collaboration with multiple organizations and has three major components: public awareness or community education, medical education, and research. For public awareness and education, we had reached over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet, many men avoid visits to their doctors out of understandable fear of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits and telehealth appointments, ongoing in-person care, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same time. In prostate cancer, screening with a blood test called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly brother or father, and increasing age, 50 and older. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for about 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert. For public awareness and education, our messaging centered on the importance of screening and early detection critical for saving lives. In 2015, we focused on Plymouth County, which led the state in Black mortality. And it had higher than state average health disparities. Black men were 2.7 times more likely to die compared to white men in 2015 in Plymouth County. By 2021, we've seen more than 55% reduction in disparities in death rate between Black and white men, reaching near parity. At this time, Black men are only 1.2 times more likely to die compared to white men in Plymouth County. This disparity level is much lower than state average. During the same period of time, between 2015 and 2021, there was no reduction in disparities in death rate at the state level. Middlesex County today has the state third highest prostate cancer mortality in Black men and the state's second highest mortality in Hispanic men. We are honored to work with Cambridge NAACP to address prostate cancer disparities in Middlesex County. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest, 5th annual conference took place in September 2021. Our summit brings together the key international opinion leaders representing every clinical expertise to review the best emerging clinical practices. This educational event showed a rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with Black heritage and or a family history of prostate cancer, should start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer longer term over a period of 30 years. In diagnostics, we have seen emergence of very accurate non-invasive tools, such as blood, urine, and saliva analysis for molecular and genetic markers, and imaging, advanced ultrasound, MRI, and molecular imaging. These non-invasive diagnostics highlight the importance of PSA screening and shifted past concerns about screening into a dustbin of history by determining which individual men have increased risk of life-threatening, rapidly progressing prostate cancer, improving early detection critical for saving lives, reducing unnecessary procedures such as biopsies and treatment, and optimizing selection of personalized care, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what clinical care will be optimal. In Massachusetts, Black men are about 22% less likely to undergo life-saving treatment compared to white men. For example, in this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research, development, and large-scale clinical implementation of prostate MRI since 1998. If your doctor recommends invasive biopsy, it is important to ask what tests are available to you to ensure that biopsy is actually needed and how to do it properly under imaging guidance. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of their prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics: MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual has a slow-growing, harmless disease and needs only a careful observation, or an aggressive prostate cancer requiring immediate life-saving treatment. Prior to undergoing invasive treatment, it is important for each man to ask his doctor if any testing is available to determine if treatment is actually needed and what kind of treatment options would work best for him. Recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, PSMA molecular imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since last August. On the left, here, we can see a regular bone scan showing limited metastasis. On the right, video shows molecular imaging demonstrated much more extensive metastasis. This information is important for selecting appropriate treatment. We are proud to have led research and development of molecular imaging since 2001. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities for Black men. It is particularly important now with so many novel diagnostics and therapeutics, ensuring high-quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Dr. String and Adam Feldman of Mass General Brigham, with the mission to save lives and deliver high-quality care. We are grateful to Latino Health Insurance Program and NAACP New England Area Conference for their support. Our mission is to expedite access to leading states experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man, age 40 and older, can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to reduce, if not eliminate, health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options available to them before and after screening, biopsies, and treatment. We stand ready to support men during every step of their medical journey. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. First, AdMeTech Foundation's coordinator collects basic information and matches individual patient needs with the appropriate state experts. Second, a clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit. Third, if an expert recommends any next steps, AdMeTech's coordinator and patient navigator work with patients on the appropriate follow-up, such as testing or treatment. To ensure a successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, developed an effective process for patient referral and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 125 program ambassadors who are community, organizational, and church leaders, held multiple focus groups to develop program materials, and our current goal is to identify and mobilize appropriate organizations and individuals to ensure that men, their primary doctors, and caregivers know about this program. Summer Mills, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Summer by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.
Thank you, Dr. Stern. That was very informative. You know, AdMeTech, I knew a lot about you, but I think I know a lot more. It was a very thorough presentation, and I'm looking forward to what we might be able to do together as we move forward. This is an important partnership with us at the NAACP in the city of Cambridge, and so I'm intrigued by what the possibility in the future holds for us. I want to introduce now Dr. Kwok Dan Trin, Associate Professor of Surgery at Harvard Medical School, Co-Director of the Dana-Farber Brigham and Women's Prostate Cancer Center, and Director of the Ambulatory Clinical Operations at the Division of Urological Surgery at Brigham and Women's Hospital and Harvard Medical School. Dr. Trin will review the recent advances in prostate cancer treatment and health disparities, and will provide his perspective on the Prostate Cancer Equity Program. It's so good to have you, Dr. Dan Trin. The floor is yours.
Hey, thank you very much. Thank you very much for everyone who presented today. You know, I think me as a physician, as a surgeon who treats 99% of what I do is prostate cancer, it's really important for me to hear from Mr. Reeves, for example, and his patient perspective. You know, I obviously talk a lot to my patients, but, you know, in an open forum, from a different perspective, it's always interesting to see and try to learn from that shared experience. So I appreciate that. I had two things to talk about, and obviously there's a Q&A, and there'll be an opportunity to answer some questions. I do want to talk about to what Dr. Stern just talked about in the Prostate Cancer Equity Program. I've been in this business, I guess, of healthcare for a decade. You know, I finished my residency in 2010, and I came from Canada, so I had a quite different perspective of how healthcare is in Canada. You know, my parents were first-generation immigrants from Vietnam. You know, came with the war on a boat. You know, healthcare over there's no insurance, right? Everybody's covered. You don't ask questions. You have something medically complex, you get the best care. If it's something simple, you go to the community hospital. And then you just take it for granted that that's how the system works. And then you come to the US and it's like eye-opening, right? I did my fellowship in Henry Ford Hospital in Michigan, got that perspective, saw how things were over there, came here. And again, it's quite interesting, or maybe more disconcerting, to see how things are and how the balances of resources is not necessarily right and equitable over here. For us, I think that the Prostate Cancer Equity Program is a move in the right direction, but it's also the recognition, because obviously Dr. Stern has been a leader in the field, but even within my institution, having seen that 2017 report in the Boston Globe, which highlighted, you know, the issues with disparities in healthcare that we have, even unfortunately in our great state of Massachusetts, is really the shift that organizations like mine recognize that there is an issue, that we need to dedicate resources, and the status quo is not acceptable. As a physician, it's easy for me to just go with the flow, keep seeing patients, and not ask myself, am I doing what I can do to provide equitable care? And am I putting enough energy into these kinds of measures? So, you know, at our organization, we have decided to create a prostate cancer outreach clinic. And this is where Dr. Stern, when patients are appropriate for a referral to our system, with insurance and all that. These patients are seen in this clinic. And for me, it's just really putting the time and the energy to address something that I've researched for a long time, but operationally, finally putting it all together as part of this project. So that's a little bit my perspective on the Prostate Cancer Equity Program. And I really hope that we'll be proud to say that 10 years from now, we made a huge difference in the state and we can be a shining beacon for how things should be done across the whole country. I was also asked to talk today a little bit about advances in treatment. I think that there's a couple of things I want to talk about, and I think that are interesting, and also interesting from the perspective of men of color and what is important. One is active surveillance. Dr. Stern talked about it at diagnosis, but this is actually true across the whole spectrum, right? If you have a small prostate cancer, we have moved away from the idea of treatment. The fact is actually the majority of prostate cancers these days are not necessarily treated, they are watched, because we know that this can safely be done. But then a couple of years ago, there were some studies suggesting that men of color who were on active surveillance had worse outcomes, were more likely to die. And the natural reaction to that is to say, aha, African-American men have worse prostate cancer. They should not be surveilled. We should just treat everyone. But the data more recently has really shown that it's more about access to care and access to high quality care, right? If African-American men are more likely to have lesions in the anterior part of their prostate, away from where you do the biopsies, right? Because when you do those biopsies transrectal, you go to the rectum, and that area that you sample is mostly in the back. But if the cancer is on the other side, the dark side of the moon, then you're going to miss it. But you won't miss it if you're getting MRIs and the appropriate, or if you're getting the right genetic testing or genomic testing to figure out if this cancer is aggressive or not. So that has been key to really making sure that we select patients appropriately for active surveillance. And once they are on surveillance, that we continue to surveil them correctly and treat them when it's necessary. And I think that's an advance that is quite important, even though it's not quote unquote active treatment, since most men with prostate cancer these days we don't treat. To do that surveillance appropriately is key to providing good outcomes. So I think that's something that's important to highlight. I think another important perspective is that a lot of research, and some of them is mine, is that men of color seem to have more concerns with side effects than white men. Now, I have my theories, and happy to field some questions and have that conversation. I think a lot of it has to do with social determinants of health. There's so much other factors that come into play, maybe some cultural differences too. And also, I'm sure all of us would agree, we don't like putting people in boxes of race and what does that exactly mean and all that. But there's definitely differences in what constitute acceptable side effects versus not acceptable side effects. And one thing that recognition has led us to obviously focus on doing treatments that are less and less invasive. Mr. Reeves talked earlier about CyberKnife, and that's definitely a way of making radiation therapy more bearable. Is that getting 28 treatments over X number of weeks may be disruptive for work. Some people can't take that time off, and having treatments that are taking less number of days may be more acceptable for certain people. And that's an example of advances we've seen on the radiation side. On the surgical side, we've all heard of the transition from a lot of open surgery, making a cut that is like 6 inches long to remove the prostate. And now there's been a move towards more robotic surgery. So like little pinhole incisions, keyhole incisions, you put instruments in and you do the surgery through that. So faster recovery, less pain. And the cutting edge of that is something called focal therapy. The idea that, well, maybe you don't need to radiate the whole prostate or remove the whole prostate. Maybe you could just focus in one specific area using, let's say, MRI imaging, and say that we're just going to treat that area, either burn it or freeze it and leave everything else alone. These things are tricky. You have to be careful when you talk about cutting edge in the world of prostate cancer, because It often takes 10, 15, 20 years to really know if that quote unquote cutting edge treatment actually worked. As we know, it's prostate cancer. If you literally do anything, the person will be alive a year later, will probably be alive 3 years later. But what happens to them 5, 10, 20 years down the road is the real test. But that is definitely a direction that we're taking more, saying that, well, for some of these smaller cancers, maybe we can treat one area, leave everything else alone, and postpone that major treatment until absolutely necessary. Interestingly, on the other hand, you have these cancers that are less aggressive, and we're hoping to cause less side effects. But you also recognize that some of them are potentially lethal, really bad cancers. And the direction that people are taking is realizing that sometimes one treatment for prostate cancer is not enough. Often you need multiple. So we heard about radiation and adding hormone therapy to it. We've heard of things like there's a trial that at the Farber where I work, we're recruiting patients for. It's called Proteus, where patients are getting hormones first, hope that that shrinks the cancer, or even make some of that disease that may have spread shrink away and come back to the prostate, and then do surgery afterwards. So that's things that are being experimented and trials that are available for patients who are interested in something a little bit more cutting edge. On the even more advanced stage, we're talking more about precision medicine, precision oncology. So the idea is that, the cookie cutter method of saying, okay, you have advanced prostate cancer, you're going on chemo, you're going on these hormones. Well, maybe it's not the same, it shouldn't be the same plan for everyone. And one of the things we distinctively know is that, genetically we're different. Every person's different. Even within race, we'll see differences. And one treatment for one person and their cancer may not be the right one for you. And one of the biggest problems we've heard, again, in the perspective of talking about men of color, is that if you have clinical trials, that's really important, right? Where 99% of the participants are white. Well, maybe the treatment that was tested in the trial works really well for white men, but it doesn't mean it works well for Asian men or African-American men. And we're moving towards an era where we can do these kinds of genetic tests that can tell us, well, this treatment may work for this person, may not work for that person. And it's no longer one size fits all. Whatever was proven in the trial, we absolutely have to do the same thing for everyone. So I think that's also an important perspective. I'm a health services researcher. A lot of the research I've done has been about equity and understanding healthcare delivery. So my last two innovations are actually not technical things or new drugs or new treatments, but really two things that I think we have increasingly recognized in institutions who care about disparities think that we need to put energy and time into this. One is multidisciplinary care. Just having these conversations of what Dr. Stern talked about and what I talked about, it is getting really complicated. It's complicated for me as a physician to follow. And one thing that's important we talked about is the importance of second opinions. But even if you're getting your care at a single institution, cutting edge, or like Dana-Farber Cancer Institute, it's not enough to see one physician, right? You have radiation options, you have surgical options, you have chemo, hormones, et cetera, et cetera. It's that we have to recognize the importance of multidisciplinary care. The idea that when you have a diagnosis as complicated as prostate cancer, you should not just be relying on one urologist. You should have a urologist who specializes in cancer, a medical oncologist who specializes in prostate cancer, a radiation oncologist who specializes in prostate cancer, and get the opinion of everyone, and in a concerted fashion, make a decision that's best for you. One thing that's scary and sometimes people don't appreciate is that, and this is bluntly and transparently, I'm a urologist. I'm a surgeon by trade. I do 200 prostatectomies a year. This is how I do my living. And as much as I want to be unbiased, I'm going to be biased towards surgery because that's what I do for a living. And same for the radiation oncologist. So having the opinions of 3 people is important for you as a patient. But even us on the side of physicians, the fact that I work as a team with my colleagues makes me also, strike a balance, because I can't say the absolute opposite of my radiation oncologist who's going to see the patient right after me. That wouldn't work. But when you work in silos, you come up to these things where everybody's a salesman on their side, and then the patient just gets confused because everybody's saying the opposite, saying, no, my treatment's better, etc. So multidisciplinary care, I think, is something that is so important for patients, especially in a disease as complex as prostate cancer. Last thing I'll say, and we've alluded so much to this as part of this conversation, the recognition that navigation is so important. You know, the patients are overwhelmed. They have so much other things to think about. There's the COVID pandemic happening. There are other things happening in their lives, financial issues, you know, personal issues. And more we recognize that, you know, in something as complicated as prostate cancer, where you get a PSA test, it's abnormal, you get sent to another doctor. This doctor does a biopsy, gets an MRI, you get to see somebody else. But that urologist who did your biopsy refers you to a specialist, and then who then refers you to a radiation oncologist. There are so many opportunities along the line for people to get overwhelmed and just say, cancel all this, I'm not getting and following up with this care. And so much energy of you folks here has been put into getting men of color to get screening and to get a PSA test. But we have to recognize that there's the whole piece that comes after that. And, you know, the data that Dr. Stern talked about, 22% less likely to get treatment, these are people who actually got a diagnosis of cancer. It means that you folks made the effort of getting that patient to get their screening test. But once they get diagnosed, there's a whole gamut of things that need to happen so that person gets timely, appropriate medical care. And this is where navigation is important, to have advocates for you who are actually going to help you along the process and not drop you because you didn't pick up the phone at the one precise moment that somebody gave you a phone call. And I can tell you that within my institution, I find it extremely frustrating because everybody's under pressure, everybody is overworked. And a lot of institutions will adopt a policy that's like, call the patient twice. If patient doesn't answer, you know, scratch that and move on. Patient did not return phone call. But people who are underprivileged need our help to bring them and keep them in the system. And this is where organizations that AdMeTech can make a difference, and me within my organization to make sure that we invest the energy in nurse navigators, community health workers who will assist and make sure the patient understands the gravity of the situation and follows through whatever is needed, is really important as part of this whole process. So anyways, thank you for the forum and the opportunity to say a couple words, and obviously happy to have a conversation about everything that we discussed today. Thank you.
So, man, thank you, doctor. I just want to say this and, you know, take this for what it is. I've been doing this 20 years, working for Men's Health, the Men of Color Health Initiative in the city of Cambridge, for the Cambridge Public Health Department. And I can tell you this, when you start talking about multidisciplinary care, you know, in the navigation, this is what has been kind of my life's work professionally, just trying to get people to understand the importance of this. And, you know, a question I'll ask you later, I'll put it out there now, but ask you later, is sort of what you touched on, that organizations and physicians are driven by their specialty. So when you talk about the surgeons, they want to do surgery. The radiologists, they want to do, you know, use radiation. That is so important. And I think the health navigation piece as well, it's just so critical, because once you get them there, you have to keep them there, and you have to make sure that the follow-up is thorough and that it's happening all the time. And I just say, not knowing you, I don't know you well, but we will get to know each other. I think if we had more doctors like you, men of color would be in a lot better place health-wise. So thank you very much for what you do. I'm going to turn it over to Dr. Stern, who's going to open it up for the Q&A. Please bear with us a little bit. Some people will come in, obviously, through the chat, and I can't really see it, but Aisha Wilson, our secretary, will help us. But Dr. Stern, why don't you begin and open up with the Q&A for the folks who have joined us today?
Absolutely. Thank you so much, Mr. Harding. I would like to start with a question for Kwok. Kwok, you are one of the most distinguished clinicians in prostate cancer care, but you're also, your research, your life's work is in health disparity. You're the world authority in health disparities in prostate cancer. What do you think about the role of PSA screening in eliminating health disparities?
That's a tricky question. There's two aspects to it. One is that I find that it's a disservice to some of our communities that we care about here to say that it's, again, one size fits all, right? You know, we know that there are issues with overdiagnosis and overtreatment of prostate cancer. But, you know, I find it hard that we're putting everybody in the same bucket, saying that it's 55 to 69 is the recommended age for shared decision-making and no distinction according to family history or race or such and such. So I do agree with you that there is definitely a role for potentially earlier screening for men who have a family history of prostate cancer and men who are at especially high risk of prostate cancer, as we discussed earlier. You may have heard, I'm sure you've heard of Tim Rebick's work. Tim is interested in the Precision Initiative, where screening patterns or guidelines would be different and customized according to race and family history, and also the PSA level. Because there's a lot of data from actually coming from my institution that has shown that, you know, if your PSA is low, it's probably unlikely you're going to get a prostate cancer, like really, really low. Whereas somebody who has a moderately high PSA may not have a prostate cancer now, but eventually may have a higher chance of getting a prostate cancer later. So there's definitely a role for more of a precision approach rather than a one size fits all, which, like I said, I hate. And I think that it's a problem in driving the disparities that we have. You know, it's a structural racism issue, in my opinion. On the other side, there's a lot of exciting developments, right, Faye? As you know, like a lot of people are saying, well, maybe the PSA is not the best marker, or at least maybe shouldn't be the main driver. There's a lot of thought in some countries. In England, they are testing an approach among men of color in England to a trial to see if you could do a screening MRI. That maybe an MRI could be a way to screen men for prostate cancer, but, you know, obviously it's too expensive to do that in the whole population, but focused and targeted in individuals who are at risk. So it's exciting to see that this kind of research is being done, and it'd be interesting to see what they find when those results are available.
Before we have sort of other approaches to screening, our summit was fairly clear that PSA screening is here to stay. How do you feel, Kwok, about the emerging role of PSA screening, given all the advances in diagnostics, so that we can, if somebody's screening highlights a problem, now we have diagnostics to sort things out, whether or not they need biopsies or treatment. How do you feel about PSA screening, given all these emerging diagnostic advances?
I still think, I mean, I answered a little bit of it earlier, but I still think that it is the best we have for now, right? And until data has proven me otherwise, proven to the world and all of us here today otherwise, you know, this should be the test that we recommend. This is the test that we should advocate for, especially among those who are at risk for prostate cancer. So I do want to say that, and that's clear. But like I said, I'm interested to see what the future holds, because there's a lot of people who think that the imaging will play a bigger role as we move forward.
And the last question about PSA, how do you feel about the role of baseline, the first PSA screening result at a younger age, around age of 45?
I'm a huge fan of that approach. Maybe it's because the person who wrote that study is my friend and colleague here at the Brigham, Mark Preston. The data is really compelling. And you know, a lot of men, including myself, I can tell you that, like, seriously, I'm one of those doctors who just got a primary care physician because I felt like, well, you know, I'm a doctor and like I should probably follow guidelines and follow what I'm supposed to be doing. But I don't enjoy going to see the doctor and getting tested and getting this and that. But there is incredibly good data. And Mark did a paper that was specifically also for Black men. So it was a paper for overall population and a separate paper focused specifically for Black men. And it showed that if you have a baseline PSA in the midlife, you know, age 40, 45, that shows that your PSA is low, the chances of you getting a prostate cancer later in your life are pretty low. And I'm not at all advocating for doing it once and never doing it again, but we can hypothesize that if your test result is low, you could probably skip a couple years and wait. And again, emphasizing that men don't like to get tested. Well, you do it once and you have a good result, then you can probably skip it for a while.
Yeah, so that's, I agree with you. I think that this first test is absolutely important in actually tailoring of future prostate cancer screening, frequency, etc., to a given individual. Now, my next question, Kwok, is what is your perspective on genetic testing, for example, germline mutation, and the relevance to Black men?
Well, I mean, we saw that the NCCN guidelines, which are always a little cutting edge, right? They tend to push the envelope a lot, are increasingly suggesting that anyone with aggressive prostate cancer diagnosed at a young age, a family history, at risk of prostate cancer, these tests have a role. And what we mean by that is that, and just to clarify in case it wasn't clear, what we're talking about is that to run a blood test. So this is not on a biopsy specimen or anything. You take blood or a swab or something, and then you analyze your genome and see if you are at risk of prostate cancer or at risk of aggressive prostate cancer. And the relevance of this is that if you have certain mutations, let's say a BRCA gene mutation, that's just an example, there's many of them, that predisposes you to aggressive prostate cancer, and maybe our approach with you will be different. So for example, let's say you're diagnosed with one of those low-risk prostate cancers, the one that I was telling you about, that 90% of the time we recommend that you shouldn't do anything and you should just watch it. But if it turns out that you have an aggressive, like a mutation that puts you at risk of aggressive prostate cancer, then maybe we'll have a conversation about not necessarily putting you on surveillance and recommending treatment earlier, because it sounds predisposed that eventually things are going to go south. It's an individualized approach, but I think that here it's empowering patients with information, like cutting edge information that can help them make the right decision for themselves. So when indicated, I think makes total sense to do it.
What is your opinion on increasing use of careful observation, what we call active surveillance, as opposed to radical treatment? Can you please share some, data indicating increase in utilization of active surveillance opposed to radical treatment that has all these complications?
Yeah, absolutely. I mean, so I want to be clear, right? There are prostate cancers that we should treat. And one of the most difficult things as a physician that I hear about is, sometimes somebody shows up with a really aggressive cancer and it says, all my buddies are just being watched, like I don't want to get treated. They told me that nobody dies from prostate cancer, which is not true. We know that prostate cancer kills a huge, unfortunately, number of men every single year. And then you have also the opposite. You have men with the smallest of smallest prostate cancer with absolutely zero chance of spread or anything. And they're like, I want active treatment. I don't want to die. The C word, get it out of me. So physicians have a difficult task sometimes, when somebody's diagnosed with cancer, they're overwhelmed and they want to get immediate treatment. Yet we know that some of these prostate cancers have close to zero potential to spread, as long as they are monitored carefully over time. There is so much compelling data on this. And the best one is from the PROTECT trial, right? In England, they were able to conduct a study where men with these small prostate cancer were randomized. So it was like, you close your eyes, you're either going to get nothing, surgery, or radiation. Believe me, this kind of study would probably not work in America, right? But in England, they were able to recruit a huge number of men with these small prostate cancer, do either nothing, do surgery, or do radiation. And believe it or not, in that study published in New England Journal of Medicine, 10 years later, there was no difference in survival. And that's crazy, right? No matter if you do surgery, you do nothing, or you do radiation, it seemed like it didn't matter as long as you have one of these smaller prostate cancer. So in light of data like that and all the series of active surveillance that starts with Lori Klotz in Toronto and other groups, Hawkins, et cetera, us at the Farber, et cetera, it became clear that these prostate cancer probably should just be watched rather than get treatment. The problem, and as I tell you the story, is that as we have heard from Mr. Harding, from Mr. Reeves, is that, you know, the doctors make a living out of doing treatment and recommending surgery or recommending radiation. So it took a long time to change the paradigms. And part of it is also like, you know, patient driven, right? You know, they have cancer and then you tell them we're just going to watch it. It's like, are you crazy? Are you giving me an inferior treatment because I'm not white, or what's going on? And then, you know, the easiest thing to do is like, okay, so fine, we'll treat you, and end of discussion. And, you know, cancer will be gone and the outcome will be probably good. But with that recognition, with the data, with the guidelines changing, surveillance has increased and increased and increased. It's a little sad that, you know, in countries, Scandinavian countries, surveillance has been at 90% since 2010. In America, if you go back to, let's say, 2012, 13, it was more like 15%. So unfortunately, for a different number of reasons, America lagged behind. But today we can proudly say that finally we've gone to a range that I would say makes sense. There's different conflicting data, but I think that these days, at least, probably 80–90% of these small prostate cancers are watched, because it's a consensus among urologists, radiation oncologists, medical oncologists. If you see one of these small cancers, unless you have a compelling reason, you should just watch them. So that's the story.
Thank you so much. We actually 3 minutes over time. Mr. Harding, to my knowledge, we do not have any more questions in the chat room.
Yeah, we have one. We have one, Dr. Stern.
Sure.
We have to ask this, and President Reeves will appreciate this. So the doctor mentioned a very compelling thing, and I say this from my lens in men's health for, as I said, 20 years as of September 10th, 2021. You have to speak, doctor, you have to speak on the comment you made earlier, why men of color have more concern with the side effects than other groups. Please, if we have to go over time, I'm sure the people on would love to hear this, because Mr. Reeves and I have talked about this ad nauseum, and I just want to hear your perspective, because I don't think I've quite heard it from a doctor who specializes in this particular disease such as you. So please, if you could close us up with that alone, this would be worth the time.
Mr. Harding, you are a mind reader. Thank you.
Do you both agree that that's an issue, that men of color are much more concerned about side effects?
1000%.
Yeah. I think there's actually compelling research, and some of research that I'm doing right now, you know, having as part of one grant that I have, I've interviewed, you know, men of color, asking around, saying, you know, why are you concerned about sexual dysfunction? Why are you concerned compared to, you know, white men or Asian men, or et cetera? So there's many things that come up, right? And I'm gonna present this in somewhat of a rant fashion, and we're still collecting our thoughts and trying to fully understand that. There's definitely cultural differences, right? What it means to lose their erections may be different culturally between different cultures. It sounds like you hear that you know, the conception of what makes a man may be different from person to person, and that has implications on their choice of treatment and how willing they are to, let's say, go for surgery, which carries a 30 to 50%, or if not more, risk of losing your erections depending on age and your current function. I think there's a part that a lot of people don't like to talk about, but you know, all these other social determinants of health and other issues, like, I'll give you an example, like, and again, this is not on the lens of race, but let's say more from occupation. If you are a lawyer and you sit at your desk all day, and, you know, like, if you leak, would anyone notice? Would, you know, I'm sorry, I'm talking about leakage of urine, for example. Would anyone notice? Would, you know, if you have a private bathroom because you have a bathroom attached to your office, you can easily stand up and nobody's in your office, go change your pad or your diaper, go back to your desk, and not have the same consequences as, let's say, you're a policeman or somebody working on the streets and in some sort of public occupation that is also physical. and then suddenly you're leaking through your pants and everybody is noticing. Well, you know, the damage, the consequence, or at least the mental strain is different if you have that job versus another job, right? You know, we think that these kinds of aspects are a lot underestimated, and sometimes we put it under the lens of men of color or race, but they're not necessarily racial issues. They're like issues related to, you know, other factors that are not necessarily encompassed, you know, through questionnaires. So that's definitely something that I have the impression that some of our research has picked up on and appreciated more. I think this is really important, and I think it's important to talk about it, and I hope to have the opportunity to discuss it further with you all here today, because a lot of times I've operated people who basically told me after the fact that I didn't want to sign up to this procedure, but my wife or some family member, my children, just forced me. They just said, "Dad, you have to do it. You know, you have to be there for us. And, you know, I know you don't want to lose your continence." And then after the fact, they acknowledge that it's not as bad as they thought it would be. But if they admit that if it weren't for their children telling them, "Go, Dad," or their navigators saying, "You have to do this," they would have just said no, which leads me to the next point I was trying to make is social support, right? You know, it sounds like if you are a single man and you are presented with these issues and that you don't have like your family around you to appreciate and see how am I going to cope with this, you just tend to get overwhelmed and say, "You know what, scratch this, I'm just going to walk out of here and not get treatment." Whereas, you know, if you're married and you have your children around you and everybody's pushing you, your acceptance of what these side effects could be could make a difference. And this is actually backed by data. I don't know if you've ever seen the study from, I think it was Paul Nguyen, that was published in a major journal a couple of years ago, is that individuals with cancer who are married have better outcomes than those who are divorced, and those who are divorced actually have better outcomes than those who are single and without children. And we think it's because of the size of their families that make a difference. And what's even more interesting about this data is that the effect was bigger among men compared to women. Like, meaning that, like, for a man, to be a man and single, you were the least likely to get treatment compared, like there was such a big gap compared to, let's say, a married man. And again, that goes with the whole social support and how that could have an effect on, or at least an interaction on, you know, do they end up accepting the side effects of treatment or not? And again, I don't want to, you know, I don't want to sound it like I hate when people stereotype me as an Asian and who I am just because I'm Asian. And I don't want to do that to anybody else. I'm just trying to present to you today some themes that I have come across. And I think that we can make an effort, you know, working with people like you who navigate patients. How can we approach this better if this is a major concern for the patient? How do we bring the family to get involved? I often don't like that when, you know, you come to the Dana-Farber, you're going to see 3 specialists, and despite having a family and children, you decided to come alone. You know, maybe it would have been better, you know, if you brought your family, maybe, you know, I don't know the context, but I think those things are extremely important. And I appreciate the opportunity to talk about it, even though my thoughts are, like I said, still in flux and still trying to understand that better.
And Mr. Harding, what I would like to comment, if we looked at the last decade, we would see more and more transition to less invasive treatment. We see more transition from treatment to careful observation, because careful observation doesn't have any side effects. We also saw a significant transition from radical surgery and extensive radiation to minimally invasive focal treatment that have comparable cancer control and fewer complications. So what I want to finish this education event on is whatever patient care looked like 10 years ago it looks completely different right now. And doctor, it is important to emphasize what Dr. Trink said. The effort that is being made by experts to administer less invasive treatment with fewer complications. Yet in some instances, when men's life at a stake, then when a choice is between saved life and complications, we recommend to save life.
There you go. So I just want to say thank you. This for sure has been enlightening and informative to me personally. I'm sure for anybody else who was with us today or will see this again. This was a high quality, highly informative, and very interesting conversation about prostate cancer, as well as how to deal with men's health in the new reality that is a pandemic. So I just want to thank everybody, starting with Dr. Trinh. Thank you, thank you, thank you. We shall talk again, I'm sure. Obviously, I want to thank AdMeTech Foundation and also my colleagues at the Cambridge branch of the NAACP, as well as the Good Samaritans. And as well, I'd also like to thank our distinguished guests, Mayor Sambol Siddiqui and Representative Marjorie Decker, for being part of this wonderful program. Dr. Stern, we have much to do and much to talk about and follow up, but I am grateful that this partnership has come together. And I think this was a very informative and fruitful conversation that would help not only men and community of colors, but the city of Cambridge and beyond really look at with intentionality how to deal with the very important men's health issue that is prostate cancer. So I think I'm going to close our session now. And thank you, Thomas, who was helping with the technical aspect of this Zoom. And I look forward to our next community conversation. Thank you all. This concludes our program. Thank you
so much. Thank you.
Thank you all.